Thanks very much, Steve. Good afternoon. We'll talk about infective endocarditis, or as Monty Python would say now, for something completely different. My disclosures haven't changed. Here's a 52-year-old man who had recently appreciated type 2 diabetes and been sick for several weeks with low back pain, anorexia, weight loss, and became febrile the day before he visited with his primary care physician. And on examination, he had low back and left flank pain with flexion of the hip. He was sent to the emergency room, of course, had a CT scan because he had pain below the diaphragm, and it showed this abnormality. In the context of fever, it looks like his left psoas muscle is different than his right. A needle was placed in the psoas, and polymorphonuclear leukocytes were aspirated, as well as gram-positive cocci in chains and clusters. So he was then admitted to the medicine service, and the following morning a systolic heart murmur was heard, and a transthoracic echocardiogram was obtained, which demonstrated that he had mitral regurgitation, but no vegetation was seen. And within 36 hours, his cultures grew a strep mutans, which is a wimpy strep, which is typically penicillin sensitive. So here's a TEE that was done reflexively.
I thought they were illegal.
Yeah. So we can quibble with this, Steve, but so he had a TEE done because of the inability to confirm a suspected diagnosis of infective endocarditis on the basis of a transthoracic echocardiogram. And Steve, please tell us what you see.
I think he either has a perforation or a vegetation, a complex vegetation, with a fair bit of mitral regurgitation at this point in time.
Okay.
The valve was sore. It looks perhaps that it was myxomatous to start off with.
All right. Does anybody see anything else? Oh, you are?
In that it looks thick a little bit, Randy, or plumped up? Just worried.
Randy, I didn't think you were a Catholic. Okay.
Maybe if you come up here and squat
we worry about
over
everything. All right. So then the question, of course, to the audience is, what are the indications for surgery in the acute phase of infective endocarditis? Do you think, on the basis of the accumulated findings that I've shown you, that this patient should be scheduled for surgery during hospitalization and before completion of a course of antibiotics? So those who would recommend surgery, please raise your hand. And those who would recommend against surgery, please raise their hand. Okay. Did everybody vote? Remember, this is Chicago. You can vote twice. All right. Cook County, I should say. Okay. So it turns out, of course, I met this patient because I was on service for the week on the consult service. And he had already been seen by the cardiac surgical fellow who had discussed his case with one of my attending cardiac surgical colleagues. And they were waiting for more information. The next day he had a terrible headache and suffered what is typically a highly morbid and oftentimes fatal complication of even wimpy strep infective endocarditis, namely that of a mycotic aneurysm, typically at the bifurcation of the third-degree vessels along the convexity of the brain, and had a spontaneous hemorrhage into the parenchyma. This, of course, would be something that would forestall a decision for early surgery should you felt that he would have otherwise been a candidate for SAME. You can see that bright spot here. Okay, and this actually turned out to be a wayward drain that was placed into his parenchyma as he began to swell, and the neurosurgical service tried to decompress the swelling, and the drain migrated contralaterally across the corpus callosum and actually introduced infection into the contralateral hemisphere. Things happen to sick patients. So, infective endocarditis is something, I think, with which we are all struggling with increasing frequency. Remember the old days when a lot of patients had rheumatic heart disease and bad teeth. and they used to present out of the Sir William Osler's textbook with several weeks to months of an illness characterized by low back pain, poor appetite, weight loss, splenomegaly, and sometimes clubbing. And they had funny skin rashes. Here's an example on the bottom of somebody who potentially would have suffered some embolic complications from endocarditis in the process. Nowadays, of course, we see a lot of degenerative disease in older patients, and on average, if you do population studies in countries, we're looking at the prevalence of infective endocarditis now, it is frame shifted about 10 years. So the average age of a patient cared for during hospitalization with infective endocarditis is about 10 years older now than it was, for example, at the early turn of the century. Now, that may actually come down to a younger age group because we are all dealing with the opioid epidemic, aren't we? And I think that certainly on our service in urban centers all across the United States and elsewhere, the prevalence of injection drug use is now so high that we are being revisited by a scourge of cases of tricuspid valve endocarditis, aortic valve endocarditis on previously normal aortic valves, and the entire gamut, especially with these highly virulent staph and streptococcal organisms that have multi-antibiotic drug resistance. And then there's the scourge of the cardiac implanted electrical device infection, which sometimes cannot be cured unless a cancer operation is performed and the entire device is taken out. The generator, the pocket is cleaned out, and both the leads. And I'll have something to say for that at the end when I show you some recommendations. Staph is currently king, with respect to the major or most frequent pathogen that is associated with endocarditis in current practice. And we're seeing a lot more patients in the acute phase of endocarditis than we did before. Here's an example of the changing epidemiology. This is a relatively healthy young man who actually is a colleague, MD, PhD, and no known prior valvular heart disease, who developed diverticular disease of the colon and some months later was found to have a small stroke in the setting of a low-grade fever and had strep bovis endocarditis, complicating diverticular disease of the colon. He went on to develop increasing degrees of aortic regurgitation and required an intervention because of heart failure. Certainly the diagnosis we think is straightforward, but then again, every once in a while these patients continue to slip through the cracks because they're treated as outpatients with antibiotics for illnesses that are masquerading as a bronchitis or perhaps a flu or some combination of that. So a high index of suspicion is needed. Blood culture should be drawn prior to initiation of antibiotics, and then of course you're off to the road races with respect to imaging in order to find an echocardiographic correlate of your clinical suspicion, something that looks mobile and that should not be in the place in which you see it. There's an increasing use of more advanced imaging to assess some of the early complications of tissue invasiveness in the context of infective endocarditis. Here's a very nice example of the utility of performing PET-CT in a patient, as you can see here, had a previously implanted valve graft conduit with a periconduit abscess that lights up like a Christmas tree following exposure to the positron agent, which is attracted to macrophages and shows this kind of metabolic activity. And you can see the extent of the infection. And when I look at studies of this sort, I certainly take my hat off to the cardiac surgical colleagues that we have that are willing to take on something as grossly infected and distorted as this with the high risks associated with it. The 6-month mortality rates are very, very high, aren't they? 20 to 25%. Actually, in some instances, they exceed the mortality rates associated with a type A dissection. And currently in practice, nearly 60% of patients are undergoing valve intervention during the acute phase of endocarditis, that is, prior to the completion of a course of antibiotics. 60%. And we all remembered at the onset of our training days 4 decades ago that that number would have been 6% or less. Perioperative mortality rates are also not low, but the incidence of reinfection of a newly implanted prosthesis in the context of acute surgery is actually very low. I don't know if it's lower with the homografts that are sometimes still thought of as being more useful than a tissue valve or a valve graft conduit, a homograph repair of an aortic root. It's a bit debatable, but in my estimation, it's whatever the surgeon feels most comfortable with in order to achieve eradication of the infection and stability of the patient. There certainly is a relationship or an association between the performance of earlier surgery and lower in-hospital mortality. These are highly confounded single-center observational studies that were put together in The Lancet now about 5 years ago, showing this relationship between the proportion of patients who were offered early surgery and a decline in hospital mortality. Obviously, this says nothing about what the patients were like, what kind of valve lesions they had, how expert the surgeons were, but there are many, many observational studies of this nature that suggest surgery plus medicine beats medicine alone, particularly when people are very sick. And we'll try to show you that in a couple of other instances. There is a single, highly quoted, randomized controlled trial for the performance of early surgery in patients with infective endocarditis, published about 5 years ago from South Korea. They looked at only 78 patients. Mean age was 47, a relatively young cohort. Half of the patients had embolization on admission. They had suffered a complication of the endocarditis at time of admission, and a third had very large persistent vegetation size, a vegetation exceeding 1.5 centimeters. About 60% of these patients were infected with strep. And they looked at a combined endpoint of death, stroke, and recurrent embolization, and noted that early surgery beat the pants off conventional watchful waiting with respect to that combined endpoint, which was driven almost exclusively by a reduction in the risk of early embolization. So if you're a believer in the use of surgery to prevent early embolization, here are some randomized data that you can rely on to help make that decision. Obviously, that's one factor among many that needs to be integrated in terms of making a decision in the acute phase. Because on the contralateral side, we know from studies dating back 5 decades that once you start appropriate antibiotic therapy in the early phase of endocarditis, the risk of embolization falls to almost a negligible frequency within 10 to 14 days. So the risk of embolization is continuously falling once you start the antibiotic. If you're interested to do prophylactic surgery to prevent embolization, it would probably have to be in the very early phases after you see patients. And remember, most of the emboli occur 24 hours before or within 24 hours after hospitalization, and very few occur thereafter. It's like aortic dissection. People declare themselves at presentation to a very large degree. Here are the indications for surgery in native valve disease. Heart failure and abscess are at the top of the list, and I think you're all familiar with this, and you're incorporating this in your practice. There are other recommendations about surgery with respect to the presence of fungal or highly resistant bacterial. Infective endocarditis. Took care of 2 patients last week, both of whom were injection drug users, both of whom had polymicrobial tricuspid valve endocarditis with lung abscesses and repeated septic embolization with progressive right heart failure and RV dysfunction. One had a multi-drug resistant staph and the other had staph plus a fungal organism. These are the more complicated, nuanced, I think, and individual recommendations or indications for surgery, namely the development of recurrent emboli with persistent vegetation on antibiotic therapy. This is your unfortunate patient who may have a small stroke and then embolizes to the hand or to the leg. Despite antibiotic therapy, you repeat the echo and they still have vegetation that could be a source of embolization. And this is perhaps the most contentious indication, that is the presence of a large mobile vegetation, particularly when sited on the anterior leaflet of the mitral valve. They tend to embolize more frequently than vegetations on the posterior leaflet or vegetations on the aortic leaflets. Size alone is usually not considered an indication for surgery, but should be incorporated into the mix. Here's a very easy, straightforward proposition. This young woman seems to have severe acute aortic regurgitation, heart failure, and progressive inability to put the finger in the dike, so to speak. Complicating feature was that she was 26 weeks pregnant. 1-year survival does seem to vary as a function of the size of the vegetation. Here's a TEE observational study from France, which is more than 10 years old, showing that 1-year survival is worse among patients with very large vegetations compared against those with smaller vegetations, although there's no randomized treatment here between these two groups. So let's get you a question before I prattle on for much longer. A 64-year-old woman with a small ischemic stroke on the day following presentation with Staph aureus endocarditis on the aortic valve, resulting in severe aortic regurgitation with heart failure and first-degree AV block. Head imaging shows no hemorrhage. When do you advise surgery? In a week, in 2 weeks, in 4 weeks, or without delay? Terrific. Okay, we're agreed there. And I think the key here, of course, is that it's a small ischemic stroke and that there is no associated hemorrhage. If I said that she had a large hemorrhagic stroke, I think we'd all act differently for fear of worsening the situation during the performance of surgery. And the practice really has moved very rapidly away from waiting in this particular context. And then a word about prosthetic valve endocarditis. This is a monster, isn't it? It's everybody's worst nightmare. Occasionally you can get by, depending on the organism and where the valve is infected. I'm sure you all have the experience of getting a few people through on antibiotic therapy. The valve stays intact. They have a little gram-negative rod bacteremia that's not quite as invasive, or a wimpy strep, and you kind of get away. But as Fred Schoen, a cardiac pathologist, continues to remind us, remember, when organisms set up shop around a prosthesis, it does so in the tissue supporting the prosthesis, and generally not on the leaflets or the tilting mechanism or any combination of that. It almost is invasive and within the tissue at onset of the infection, particularly if this were a staph. Obviously, antibiotic therapy alone is not going to manage that particular situation. And Staph aureus on a prosthetic valve is associated with a significantly higher hospital mortality rate than infection with any other organism. Prognosis in infective endocarditis can track to patient-specific risk factors, such as age and the presence of comorbidities, whether it's prosthetic versus native valve infection. There are organism-related infections. Be wary of staph, particularly MSRA. Vegetation-related factors. I showed you the slide. The bigger the vegetation, the worse the outcome. And then complications, particularly that of stroke and the development of heart failure. And I do think it's fair to say that in the current practice, surgical treatment in the right patient can be associated with a marked reduction in hospital mortality rates. Obviously, then it's up to us to follow these patients very carefully over time with a team of individuals that are surrounding the patient who have an interest in infectious disease, neurologic complications, neurointerventional procedures, and general cardiology. Thank you very much.